If you're in the situation where you have no useful skin and fat at the tummy, or skin and fat at the medial thighs, or tissue at the buttocks, and if you've had radiotherapy, so you're not a candidate for an implant-based reconstruction alone, then the use of the latissimus dorsi muscle as a reconstruction could be considered. This takes skin from the back with subcutaneous fat on top of the muscle to give us as much volume as possible. We leave the flap attached by its vessels in the armpit and then can swing it from the back onto the chest. This leaves you with a donor scar on the back. There is, and it's important to consider, a 1 in 10 risk of stiffening and weakening the shoulder. And of course you still have an implant which will behave less like a normal breast than a fully autologous reconstruction. Now, if you happen to have enough tissue on the back to enable us to make a reconstruction or breast of good volume without an implant, then I think the LD muscle is a much better technique to consider. And we can often increase the volume of tissue with subsequent procedures to inject fat into the reconstruction from elsewhere. This would be an autologous or extended latissimus dorsi flap.
Traditionally, it is thought that recovery from implant-based surgery is shorter than other types of reconstruction, and though this may be the case, it still does take quite a few weeks to get over the whole process. A breast implant is a prosthetic device made of an outer silicon shell and an inner soft silicon substance. The idea is to try and match the size of the implant to the dimensions of the patient's breast at the time of reconstruction in order to try and match the contralateral breast as best as possible. With regards to implant-based surgery, there are certain situations in which an implant may work better for one patient versus another. Situations that are favourable for implant-based reconstruction are a small to moderate breast size, patients not requiring radiotherapy, bilateral surgery, because of course having the same operation to each side tends to give more meaningful symmetry and balance, and implants tend to behave in the same way. And finally, patient choice. Ultimately, as surgeons, we're here to guide the patient in terms of what kind of reconstruction we may feel would be best for them, but ultimately it's their decision. And some patients decide to have an implant-based reconstruction because they feel the recovery may be quicker and it may be right for them at that point in their life. All surgery carries potential risk, and there are certain important risks for patients to understand who are undergoing implant-based reconstruction. The risks can be stratified into early risks and late risks. Early risks include implant infection, such that the implant has to be removed, leaving you with a flat chest for a period of time before it can be reinserted. Other risks include bleeding and need to go back to theatre, and asymmetry at the time of surgery. Later complications of implant-based surgery include shape change. This can be either painless or painful and is termed capsular contracture, where the body naturally forms scar tissue around an implant, and this can contract and distort the shape of the breast, requiring reoperation. Other later risks include infection, late infection again, as well as implant rupture and silicon leak, which can either be contained within the breast capsule or occasionally can leak outside of the breast and into the breast tissue and associated lymph nodes. Having an implant-based reconstruction involves a commitment to the need for further surgery in the future. If the patient is young, they may be committing to the need for several further operations in the future, because implants do tend to have a certain lifespan, and if they develop shape change or asymmetries, they may need further corrective surgeries in the future. Breast implants can be placed either underneath the chest muscle, the pectoralis major muscle, or on top. Implants placed on top is referred to as a pre-pectoral breast reconstruction. This has gained increasing popularity over the last few years due to the development of acellular dermal matrices, which are pieces of tissue which enable breast and plastic surgeons to better support the breast implant underneath the skin and control the shape. One of the benefits of a pre-pectoral reconstruction is that the chest wall muscle is not lifted, and therefore the recovery is potentially quicker and it may be less painful for the patient in terms of recovery. There are, however, some disadvantages. It is a relatively new technique, and because there is less covering or padding over the implant, you're more likely to notice the implant either in terms of visibility and rippling and indeed palpability. Because prepectoral breast reconstruction is a relatively new technique, the long-term outcomes are not yet certain. One thing that does appear to be the case is that the recovery and discomfort tends to be slightly quicker than for implants placed underneath the muscle. However, there are potential downsides. Because the implant has less covering or padding, patients are often more likely to be able to see the edges of their implant and also feel the edges of their implant. If this is in the inner aspect of the breast, in this position, that's often referred to as rippling and can be noticeable in the cleavage. It is sometimes possible to correct this abnormality by transferring fat into the breast in order to disguise the rippling of the implant. Implants come in two main shapes. They're either round or anatomical. Different shapes and sizes obviously will suit different patients. This will be discussed with your surgeon. Reconstructive breast surgery following mastectomy using implants has to a large extent been revolutionised by the development of acellular dermal matrix. This is commonly referred to as ADM. Essentially, it is a product derived from animals, most commonly porcine, pigs, or bovine, cows or calves. It is usually skin that has had all of the cellular components that may normally react with the human body removed, so that it is essentially a relatively inert substance. Thinking about it simply, it is essentially like a thin sling of leather, which allows the lower portion of the implant to be better controlled and also to add a degree of padding between the implant and the overlying breast skin. Alternatives to acellular dermal matrix, or ADM, are known as scaffolds. These are slings which are wrapped around a breast implant, and they can either be made of absorbable or non-absorbable materials. Common materials in use for scaffolds include silks, absorbable materials such as Vicryl, which is used in surgical sutures, and also titanium. Scaffolds are specialist materials used by some surgeons for breast reconstruction. It is important that you have the opportunity to discuss the pros and cons of these fully with your surgeon should they wish to use them in you. Recently there has been a lot of press attention regarding ALCL, which is a type of malignant process associated with breast implants. It presents as a late seroma or shape change in the breast. This is most often painless, and the patient may notice swelling several years after the original implant-based surgery. ALCL is incredibly rare. It is associated with high-textured implants, many of which have now been withdrawn from the market. It is important, if you are having an implant-based reconstruction, that you discuss the type of implant used with your surgeon and the potential overall risks and benefits. Radiotherapy is often required as part of the treatment for breast cancer. This can, however, have potentially deleterious effects on any form of reconstruction. It is important that your oncologist, breast surgeon or plastic surgeon discusses the potential risks and benefits of this with you, since this may affect the best timing of your reconstruction, whether it should be immediate, i.e. at the time of your mastectomy, or delayed. Potential deleterious effects of radiotherapy on implants are mostly related to capsular contracture, that is the formation of thickened scar tissue around the implant, which can lead to a distortion of the breast shape and often pain. If you do undergo any kind of implant-based surgery, it is a government requirement to enter your details onto an implant registry. This is to enable us to keep track of all patients with implants so that outcomes can be appropriately followed and audited.
The drive in treatment of breast cancer has been away from full mastectomy towards breast conserving techniques, and where appropriate, our oncoplastic colleagues are expert at performing this. And without taking the whole of the LD muscle from the back, options are available for reconstructing the lateral half of the breast, say, using other options such as the TDAP flap, which rather than taking the whole muscle from the back, just takes the vessels that supply it, the thoracodorsal artery perforator. And this leaves most of the muscle on the back. You still have a donor scar, but it can provide your own tissue for reconstructing portions of the breast. Other options for this include something called the LICAP flap or the MICAP flap from other perforators that supply the skin around the breast.